Welcome to this podcast for the European Respiratory Journal. My name's James Chalmers. I'm the new deputy editor of the European Respiratory Journal, and I'm very pleased to be joined today by Dr. Anthony De Soyza from Newcastle University in the UK and Dr. Timothy Aksamit from the Mayo Clinic in Rochester in the United States to talk to us about the RESPIRE trials, which are two randomized controlled trials, the largest ever conducted in bronchiectasis, which are published this month in the European Respiratory Journal. So I'm going to start with the first question. Can you please summarize for us the key findings of the RESPIRE trials?
So I'll kick off with that, if that's okay. Thank you to everybody listening from Newcastle. So the RESPIRE1 trial was a trial of phase 3 informed by results from the phase 2 trial. It's a large study, 416 patients, and the patients were randomized 2-1 active to placebo. Patients were treated over 48 weeks, either on a 14-day cycle of antibiotics with a 14-day off period and then back onto treatment, or 28-day cycles. And I guess the key finding in this study, which excited us when we got the data, was there was a reduction in the co-primary endpoints. There was a reduction in exacerbation frequency in the actively treated arm on the 14-day cycle of 0.6 events in the year compared to those in the placebo arm of 1 exacerbation per year. And it also prolonged the time to first exacerbation, which in the placebo-treated group was 168 days as a mean for time to first exacerbation, where it was 336 days or longer in the 14-day cycle. Very interestingly, the 28-day cycle did not have this positive readout. So I might pass you over to Dr. Aksamit now to tell us about the RESPIRE2 trial.
And in follow-up with Dr. De Soyza's overview, the RESPIRE2 trial was designed identically with a 2-1 randomization, again for the cipro 14-day on, 14-day off, and 28 days on, 28 days off, compared to placebo. There were 176 people randomized to 14 days, 171 to 28 days, and then the pooled placebo were 88 and 86 respectively in the 14 and 28 day cycles. There are some differences that we will discuss in more detail as the discussion carries on, and both the arms on the RESPIRE2 program did not meet statistical significance, although there was a larger trend and signal in the 28-day arm, which was in contrast to, as Dr. De Soyza says, with the RESPIRE1 program.
Okay, so we got very excited that we had the first 48-week trial of an inhaled antibiotic in bronchiectasis that showed a positive signal for exacerbations, and then failed to replicate in the second trial. So the obvious question is, with those big differences between the two studies, can you speculate on why we saw such differences between two identical trials?
So from a RESPIRE2 program, some of the differences that occurred were twofold. One is that the countries that enrolled were more heavily weighted. Both were international multi-center studies, but the RESPIRE2 had a much larger representation across Eastern Europe as well as Asia. There was not clear differences between the demographics, although the number of individuals demographically that had a COPD in the RESPIRE2 program were in fact higher from RESPIRE1. The entry criteria for both programs required that bronchiectasis was the primary diagnosis of entry and not a primary diagnosis of COPD. The other issue that occurred is that there were some statistical differences between the two studies as well. Again, we'll get to that as the discussion unfolds.
Okay, so we heard a few possible differences there. I wonder, Dr. De Soyza, from the RESPIRE1 point of view, do you have any thoughts on differences between the studies?
I mean, it does seem that although the inclusion and exclusion criteria for the study were exactly the same, there does seem to be I guess, heterogeneity within bronchiectasis, even allowing for those entry criteria, and that's mapped out between the two studies with differences in ages and difference in ages in rates of comorbid COPD. I guess the other thing is just looking at the international catchment and that slight variation. There was probably heterogeneity in the background treatment, and certainly I'm pretty sure how we record exacerbations varies from not only country to country but within sites. So I think that's one of the challenges is these studies, how we quite group them together or cannot group them together is perhaps some of the current ways we approach trials can't factor in that variation across multiple sites and across multiple healthcare systems.
I might expand on that heterogeneity and to a large extent the importance of a priori definitions. And as we start to ponder what the lessons learned from both RESPIRE1 and RESPIRE2, I would share with you also in RESPIRE2 that the overall event rate, the number of exacerbations, was in fact lower than anticipated. The overall event rate for the whole cohort was at the level of 0.6 per year, essentially, and the enrollment criteria getting into the study were that these were frequent exacerbators defined by a historical number of exacerbations of 2 or more in the past year with a pre-specified pathogen present. The point to a large extent and what we need to be mindful as we move forward is that we did not have a standardized and validated definition of exacerbation going into the study, and the drop in the event rate to less than 1 and 0.6 overall is far lower than what had been anticipated, and as a consequence, probably contributed substantially to the lack of reaching statistical endpoints. So we need to be mindful as investigators and certainly clinicians of how we a priori define exacerbations, not only for enrollment into a study, but then as a study unfolds and as additional analyses, including sensitivity analysis for the definitions comes out, I think we'll learn some additional important lessons there.
I think I'm imagining lots of people listening to this who use inhaled antibiotics will be looking at these two trials as by far the largest studies to inform us on the efficacy of inhaled antibiotics. And I think they'll be wondering, what does this trial tell us about which patients will benefit from inhaled antibiotics? So under what circumstances, or what do you think we've learned from these trials that can help the clinicians listening to decide which patients are likely to benefit?
From my standpoint in the RESPIRE2 program, I would again share that the trend analysis and the signal were positive for cipro-DPI in both treatment arms. And although we didn't meet statistical endpoints, the signal, much like RESPIRE1, was concordantly all in the same direction. And in fact, I think one of the lessons and the takeaway messages for clinicians is that inhaled antibiotics, as most of us understand, are not for all patients with bronchiectasis, but for a select cohort. And I believe, based on the data presented, that there are clinically meaningful improvements in patient outcomes, not only with event rates, with time to first exacerbation, frequency of exacerbation, but also trend analysis with quality of life issues that were done, and then subgroup analysis, not done for secondary endpoints, given the hierarchical nature of the statistical endpoint. And the point here is that if we use the inhaled antibiotics in the proper populations, in this case, frequent exacerbators with a clear definition, already having baseline and chest physiotherapy and other aspects, this is the group that will likely most benefit based on this data.
If I can add another point, I guess one of the things that we've learned, and this has been seen in the COPD trials, is that the pre-entry exacerbation frequency falls in both COPD trials and now in bronchiectasis trials, even in the placebo arm. So I think what this tells us is that we need some better tools to work out which patients are going to continue to exacerbate. So in RESPIRE 1, the placebo arm exacerbated at one event per year, as it were. So it's quite a big difference between that and RESPIRE 2. So I think just trying to understand a little bit more why those patients behave differently was going to be really important. So clinically, I guess we're saying that the trend analyses, the sensitivity analysis said there was no particular subgroup that did better or worse with these, just the event rates were much slower than predicted. So we need to find a way clinically of enriching these, both for our clinical practice and trials, for the patients are going to stay much more towards that event rate of 2, so that we can show the differences. I think the other important thing is that in terms of biomarkers, we don't really have a robust biomarker yet that says this person's most likely to exacerbate. In fact, possibly one of the best will be their past history. So we really need to work out where the threshold for that exacerbation rate is going to be, such that perhaps 3 is a better number, and therefore patients are more likely to have 3 exacerbations, and for us be able to show in the clinical trial setting that there's a kind of consistent benefit. But the other point is we want to touch on this further, but there has been some skewing towards trials of inhalation antibiotics in bronchiectasis towards those with Pseudomonas. That's completely understandable because they often have the greatest healthcare impact in terms of requiring intravenous antibiotics and hospital care. But what we saw in both studies, those who had non-Pseudomonas exacerbations as a cause for entry into the trial also exacerbated. So there's definitely an unmet treatment need in those patients without Pseudomonas.
That's very interesting because, as you say, there is a concentration of treatment with current inhaled antibiotics in the Pseudomonas population. So it sounds as if we've learned a lot of both clinical lessons and also lessons for the design of future trials from these 2 studies. What I've heard from both of you is that we need better ways to enrich patients with the frequency of exacerbations, and maybe using a higher cutoff for future trials may help to achieve that, and also better ways of detecting exacerbations in future trials. Are there any other major messages or design features you think that you would recommend to anyone designing a future inhaled antibiotic study?
I might propose and encourage investigators or those thinking about future clinical trials to refer to a ERJ statement on definition of exacerbations to better inform the clinical investigators to who should enroll, as well as then how to best account for this exacerbation event rate in a clinical study. We should look at quality of life measures as well. Unfortunately, the current tools, including the QOL-B, may not be exactly what we need for exacerbation monitoring, and that is another topic that warrants additional investigation on whether or not we have the best tools. We think that the St. George respiratory quotient is long-standing. We're all familiar with it, but it's not been validated, and it's clearly not the best tool, much like the QOL-B, for exacerbation rates. The other plug I would encourage investigators, there hopefully will be a statement coming up addressing this issue that Dr. De Soyza brings up, and that I think most of us are mindful of, is the heterogeneity, and specifically is how do we define bronchiectasis? And we understand that given this heterogeneity and potential overlap with primary bronchiectasis versus those that have obstructive disease versus both obstructive disease and bronchiectasis, whether they, in their natural course of the disease process, have a similar outcome is yet to be determined. So we need to a priori define this, and the ERJ journal is going to be a very important instrument to help inform the bronchiectasis community internationally.
Yeah, a couple of other points to add on to those excellent ones there from Dr. Aksamit. I guess the key thing that I think many people hold very true is not translating a cystic fibrosis-related antibiotic therapy directly over into bronchiectasis. I think dose finding would be very useful, and the optimal dosing regimen, as you saw this positive signal for the 14-day cycle in RESPIRE1 that didn't show through in the 28-day, means that we don't know how how frequently to try and suppress the bacteria. And of course, one of the questions is that is often asked in these was, do you not think you would have got an even better result if you'd done continuous antibiotics? And that's something that we as a community need to address, because of course, the longer you give an antibiotic, the more likely it is to be resistance. And so we perhaps need to decide as a group, would we be accepting of resistance if we reduced exacerbations? One could argue that detecting resistance in these sort of studies is actually a biomarker of compliance. And I think that's another challenge we need to start working with our patients and saying, we may have this fantastic treatment, but it could be quite intensive in terms of, say, a complex nebulized regimen. So we need to start doing that work with the key stakeholders, the patients, and what they're also comfortable to take. The other aspects I think that are important for us to understand is potentially thinking about how new treatments might fit in, particularly if they're new licensed medications that are on patent, whether there should be an expectation of some minimal baseline treatments such that developing healthcare economies have said, well, we've already started the patients on these sort of treatments, and only at this point would we be willing to pay for a new expensive therapy potentially. So I think those are also things for people to say. I think a minimal set is the patient has well-characterised bronchiectasis. They're already been taught to do physiotherapy. After that, they're still exacerbating. We probably want to measure the sputum, at least in phase 2, and we want better quality of life markers as well. The last point I'd like to make is in the COPD world is that increasingly the feeling of unreported exacerbations as being important drivers of major exacerbations. To date, none of the studies have used any of the symptom diaries, for example, on a large scale certainly, and none of them used electronic data capture. So our concern is, although our event rate dropped in these studies compared to entry criteria, perhaps it didn't. In fact, the patients just knew they were at the end of a phone line to go and see the trial centre and self-managed or just worked through more minor exacerbations where they might have taken antibiotics. So I think having those and understanding the impact of them would be really important in the future too.
That's really, really helpful. I want to thank you both for providing us with so much interesting information and insights into the RESPIRE1 and RESPIRE trials on today's podcast. These two landmark trials in bronchiectasis are now available to read on the European Respiratory Journal website. We're delighted that you two, as the authors, chose to publish these trials in the European Respiratory Journal, and we're very grateful for you joining us for this podcast. Thank you very much.
Thank you. Could I just round up by thanking all the sites and the participants who agreed to enter this study? I think it has helped us understand the complexities in it, and without all those people involved, we wouldn't be here today. So thanks to all who helped.
Yeah. And I would also thank the ERJ for their support to proceed with the publications and the partnership with industry that I think is a model that can be carried forward for other products as they get developed and come to market. These trials are large, expensive, and take a fair amount of time, and without working together as partners between investigators and industry along with our patients, these types of improvements and data won't be available. So I wish to also express my appreciation to those involved.